I think we can get started right here on the dot. Thank you to everyone who has joined already, and hopefully we'll get a few more in the next couple of minutes. When you sign in, please make sure to put your full name. Sometimes it looks like you're a guest, and then we can't record your attendance to give you credit for being here today. And certainly that helps with getting CME as well, if that is important. To do that, if you click at the participants at the top of the box, you can rename yourself. And then if you're having any issues, you can type into the chat box, and Betsy can look through the chat box and try to respond to you throughout the meeting if anything comes up. All right. As per usual, I'll go through and do the data review, and we've got a special kind of focus on our open suprainguinal bypasses and open aortic aneurysm repairs. We've noticed over the last number of sessions that we've had worse than average outcomes for these operations, which is unusual for us because our region usually does better than the national average for everything else. And so at the last meeting, we talked about how we needed to focus in on that, and Dr. Long has some updates there. And then of course, also thank you to Lynn Hampton, who is our lead data manager living in Asheville. Lynn, do you want to say hello, or do you have anything that you'd like to add? I think she might have muting issues. But she is here. We've already spoken this morning. And then Lila Murphy, who of course is from our region, but also representing the national level PSO, is on the line with the rest of the PSO staff. So thank you all very much for being here. And I see Lynn's on now. Hey, Lynn, do you want to say something?
I was just talking away. How about mute? Thank you, everybody. Happy Friday morning. I appreciate you taking the time to join the meeting. I'm looking forward to looking at the data. So thank you.
All right, so a couple of housekeeping issues before we jump in totally. If you go into the VQI website, your center characteristics should be updated. Sometimes there's different changes in facilities or contracting. And so please go through and make sure that your facility information is up to date. The agenda is here. I kind of jumped and talked a little bit about the regional data review already. We'll get the normal updates from the arterial and venous quality councils as well as the research councils. I'm super excited to invite Dr. Spangler from University of Alabama to talk to us about the enhanced recovery after surgery aortic guidelines. We'll have a nice keynote speech from her, and then time to do breakout rooms after that to discuss ERAS and the information that she shared with us and how we might be able to use it to improve and standardize our aortic practices in our region, and hopefully help influence our outcomes in a positive way. And then Betsy will finish up at the very end with the national VQI updates. One thing that I'll pull you on at the end of the meeting is how you want to do these meetings going forward. I was thinking that perhaps doing one in-person meeting and one virtual meeting per year would be nice. There's a lot more participation and room for kind of creative ideas and practice sharing when we're in person. I think that works better than the virtual breakout rooms. But I know that travel is still hard, and sometimes getting away just for a one-day meeting can be a challenge. So think about that, and please ask the physicians who are not on the call today what they think about that, and we'll be taking a vote. Okay, no disclosures from any of us speaking today. And we've got such a robust regional group. There's tons of us who participate, and I would like to specifically highlight Lexington Medical Center, who has just joined us. Welcome. And here we go, diving into data. So just as a review to catch up to make sure all of you understand what I am talking about over the next number of minutes, all of these are results through January of this year. And all of the inclusion exclusion criteria are listed at the top of each report. So if you want to go back and look specifically, you'll have the information there. To be presented in the figures, our region has to have at least 3 centers that participate, and they have to have at least 10 cases completed for the regional results to be displayed. And if there's a little star above any of the bar charts, that means that there's a statistically significant difference. Continuing on with updates about the way that we're doing the reporting is there's something that's really cool that the VQI has added, and that they're showing us the number of centers displayed. And so out of all of the centers in our group, we'll now know how many of them are doing at least 10 cases and how many are doing any cases. And that helps get a better sense of the volume of the cases that we're doing and how we're doing with the reporting. And there's more specific volume information for each procedure for all years. And I'll show you a little bit of that in the next couple of slides. There's been a few small report updates. Now the thing that's called TFEM-CAS, which means transfemoral carotid artery stent, also includes brachial radial access, and some of the nomenclature in the EVAR guideline is lined up better with the actual practice guideline, but there's actually no report changes. So here we go on the dashboard. Blue is where you want to be on your individual center reports. That's in the top 25th percentile. Coral is things that need to be worked on. Then they've also divided out and have the 10th percentile and also the 90th percentile. But those are not as color coordinated. So here's the volume appendix that I was just mentioning, and I think this is really nice. And so, for example, you can look here at transfemoral carotid artery stenting in asymptomatic patients. In our region, there was 119 included cases, and 14 centers had cases, but only 2 of them had at least 10 cases, and only 1 of them here on the far right had at least 10 complete cases with full information filled out and the long-term follow-up. And I think that this is really helpful. You know, we have seen a big trend in, increase in TCAR, and you can see that now reflected. And so, for instance, if you look at the comparable TCAR asymptomatic, we've done significantly more cases, 311 at more centers. 12 centers had at least 10 cases, and 12 centers have had follow-up on those cases. And so you can see how the shift in the practice pattern has happened, and it helps give us a really good sense of who's doing what kind of volume. I think this is going to be important as we take a deeper dive into our aortic outcome. So if, for instance, here, this is open AAA repairs in hospital mortality for elective cases. This measurement is based off of almost 200 cases from 12 centers. Of those 12 centers, 9 had at least 10 cases. And the procedure volumes overall have been really good. A lot of us do a lot of cases and record all those cases into the VQI registry. So thank you for the continued work there. And you can see, compared to everybody else in the country, we're really active and participate a lot with the data registry. And this is just historical from the time that we started until now. And it's about the same, very active and have been for forever. This is the physician specialties across the VQI, and I'm going to flip to the next one because it's in our region. You can see that we're pretty much in sync with the distribution of specialties that participate in VQI, similar to what's in the country and similar to our region previous years. We're mostly vascular surgeons in this group. However, do have a slightly increasing number of cardiologists, radiologists, and some of these other groups. And I want to highlight here the podiatrists and others that may be more involved in PAD care and wound care starting to inch up, which I think is great. I want to congratulate everybody for the concerted effort on long-term follow-up. This was something that was a national agenda item. And of course, long-term follow-up really is the most important thing for assuring that our patients are getting quality of care, because it's not just the operation you do, of course, but all of the medical management and surveillance that you do afterwards. And Our region has improved from last meeting and also better than the national average across the board in everything that we're doing, except for recording IVC filter removals. You can see this just graphically, and here we are. So anything that is to the left here, we have more long-term follow-up than the national average. All right, discharge medications. We always do awesome on this one, and we continue to. So thank you very much for paying attention to aspirin and statins. With VQI data, it's been shown that this prescribing aspirin and statin after vascular intervention is one of the biggest things you can do to reduce mortality. And everyone in the country is continuing to do better, and so are we over the last number of years, and we're consistently around the 90% mark for aspirins and statins. And again, to the left of the screen here down at the bottom means that we're doing a great job, better than average, and we're statistically significantly better, which is fantastic. Diving into the carotid work, I mentioned this a little bit before. We were doing fewer transfemoral carotid artery stentings for both asymptomatic and symptomatic patients, but more TCARs for asymptomatic and symptomatic patients. CMS just expanded the criteria, saying that TCAR is an appropriate stenting intervention, not just for high-risk patients. And I just happened to see in one of the latest episodes or volumes of JVS that TCAR outcomes for not just high-risk patients, but for everyone seem to be equivalent. So I think that clearly we are doing a good job. Transfemoral stenting is getting less and less common, but we're still doing a good job of it in our region. So those of you who are doing it and recording it, we have not had any observed stroke or death in the last year. And that's kind of bounces around just because the volume is not so consistent. But you can see that, you know, somebody in 2018 in our group in the light blue must have had a bad outcome from a transfemoral stent, but no one has in the last couple of years, which is great. Similar, you can see here. So this is like the extra. So here we have 0 of 14 centers displayed. And so what this means is that in our group, we have 14 centers who participate in the transfemoral carotid artery stenting module, but none of those 14 did 10 cases. And so we can't get the breakdown of the information. That's true for the asymptomatic patients and also symptomatic. We continue to do very well treating symptomatic patients with transfemoral stenting and have a less than national average stroke and death rate after these procedures. We did about 100 of them in 2021. And you can see here, the light blue is the Carolinas region. Our outcomes are slightly better than national average. And here there's 13 centers who are displayed doing transfemoral stents for symptomatic patients. I don't understand why it's 14 centers for the asymptomatics and 13 for the symptomatics. Because all of the centers, of course, are in the transfemoral stenting registry. But it just may be that that one center didn't actually have any patients with symptoms. And so that's why it's recorded this way, which again is reflective of the low volume. But here, at least, we're doing more transfemoral stenting for symptomatic patients. And there's 5 centers that have done 10 cases. Moving on to TCAR, we continue to do well with TCAR. Honestly, in this region, we've got a ton of stroke patients, and open surgery, you'll see on the next slides, we're doing just as well. So you guys are doing a really phenomenal job with patient selection and technical steps, as well as the postoperative care. TCAR for asymptomatic patients, we have only a 1% stroke or death rate, which is less than national average. And you can see again, you know, that bounces around a little bit because the volumes are not too high, but we're doing well and better than average. And there's many more centers who are doing more than 10 TCARs, 12 out of 24 who participate in that module. And you can see here, it looks like one center probably had 1 stroke or death. For symptomatic patients getting TCAR, we did have a slightly higher than national average stroke or death rate, and slightly higher than would be expected. But this is not necessarily statistically significant. Here, pictorially displayed, I think that the difference over the last 4 years is probably nobody had a stroke here in 2018, and maybe 1 or 2 people did here. But again, this is something we should just be mindful of and careful of, especially as TCAR becomes more widely available and is used more ubiquitously. We do have 8 out of 20 centers displayed who are doing more than 10 cases. And here you can see the couple who had the bad outcome that skew the results. But this makes us look like we're doing worse than national average. But again, I think it's just a matter of a couple of patients, but be mindful. We continue to do an excellent job with open carotid surgery. Our asymptomatic stroke and death rate was only 0.2%, which is significantly less than the 1.4% in the literature and the 0.9% in the VQI overall. Here you can see that pictorially, and here too. And so we've got plenty of people who are doing at least 10 carotids every year for asymptomatic patients and are doing a great job with it. And same for symptomatic carotids, only a 1.5 observed stroke or death rate, which is way better than the 3 to 6% rate recorded in the literature and better than the 2.2% in the VQI overall. So congratulations. Plenty of centers participating, only a couple probably had 1 or 2 patients with a bad outcome. And here we are way on the left-hand side of the chart, doing quite a bit better than the rest of the regions. Okay, length of stay. This is something that from years ago we worked on quite a bit, and Dr. Hallett is the one who suggested that we stop using Foleys in the OR, or at least take them out as soon as we're done before the patient leaves the OR, because we, through talking at one of our meetings, discovered that it was really just older men getting anesthesia who had some BPH with urinary retention that was delaying discharges. And ever since we kind of came up with that, which has got to be at least 5 or 6 years ago, our length of stay has been about in line with national average. Most people going home after just 1 day, 20% of people staying for more than 1 day. And that's been consistent and better than national average. For symptomatic patients, of course, they have some stroke rehab and PTOT that needs to be done and coordinated. And so 40% of the patients are staying more than 1 day, which is in line with national average. You can see the graphics here. All right. While we're on the length of stay process, the EVAR, we'll shift to aortic stuff. The length of stay greater than 2 days is something that is getting focused on here nationally. And that's, in line with what's going on here. You can see on the graphs. And, everybody is about the same here. I think that the same kind of principles for EVAR can be used with the carotid patients. Some people might be concerned about kidney function and after contrast loads in EVAR. So maybe it's worth it to keep the Foley in some patients, but I think for the most part, that's probably unnecessary and maybe delaying care. Also being very clear about the up out of bed guidelines. So patients aren't spending unnecessary time flat and can get up and ambulate on the day of surgery. I think will help them get out sooner. One of the humongous initiatives that all of us have been talking about for a few years now is the sac diameter reporting. And this is something that everyone continues to struggle with. In general, we're kind of just bad at following this guideline across the entire VQI and in our region. And, it's really hard because a lot of times in notes, you just say sac size same or sac size, growing, don't see an endo leak. And you don't actually put a measurement to it. So then the data abstractors can't go back and put in a measurement. And so we're doing the work, we're seeing the patients, we have good long-term follow-up for the EVAR patients, but the best guideline-based care says that we need to be tracking the sac diameters. And whether or not we're doing it, we're not writing it down, and then it's not getting entered into the registry. I think that the places that have done this well, from last year's meeting, we talked about this, just have it in their template. And so then that way it's just an automatic thing that everybody knows that they have to fill in. And folks who don't use templated notes have more variability. So hopefully we can continue to work on that. And if any of you have any creative solutions, I'm happy to hear them and share them. And here we are, we decided to unblind this. And so you can actually see who the centers are who do well. So Novant and Prisma and Mission are all the ones here who are statistically better than the region overall. And we did a crow and confess, and they each crowed that they do a good job with templated notes. There's a few others who have been kind of in the middle who have gotten incrementally better. And so kudos to you all for doing that and for taking the time to make this a focus. Thank you. And here we are, better than national average, but still only at 65%. All right, so this next, I think that the aortic guidelines and the aortic module in the VQI, we've really tried to align them so that way we can do a better job of making sure that we as VQI members are following best clinical practice guidelines. And so this slide here refers to the fact that 80% of us are doing guideline diameter care. And so greater than 5 centimeters for women and 5.5 centimeters for men. Now, of course, there's going to be reasons that you need to deviate from this, but in general, the majority of our patients should meet size criteria for repair, and we shouldn't be repairing small aneurysms. And I think that, I don't know exactly what the right percent should be, but shooting for somewhere around 85, 90% of guideline-based care on the diameter seems reasonable to me. And we're almost there, and we're better than national average on following the guideline. So again,
Kate, quick question on that.
Yeah, go for it, Taylor.
Are anybody making any exceptions for saccular aneurysms, maybe sub 5 centimeter aneurysms? I mean, 5.1 saccular aneurysm in a male and a, I don't know, 4.7 saccular aneurysm in a woman. Is anybody doing that?
I don't know the answer to that. I do know that if you've got iliac aneurysm in addition, that you count as meeting guideline-based care, but I don't know about saccular. And this is where I said, and certainly the relative size. If you've got a woman who happens to have, a 12 millimeter aorta, then there's no reason that woman needs to wait until she's 5 centimeters aneurysm size. And so there's going to be instances like that I think it's completely appropriate to fix the aneurysm. But those are kind of the exception, not the rule. And, being at least 80%, which is where we are, I think means that we follow the rules and we do a good job of following the guidelines and we're not doing inappropriate care. But I don't know how many patients have these other types of aneurysms or other considerations and what that goal should be. That's maybe
the only reason I bring that up is that I think we did Journal Club in Lila, and you can speak up if you have it, but there was an article I think presented out of Boston where when they looked at the number of aneurysms being repaired that were under size, so to speak, it looked like a huge number. They did not break that down into how many aneurysms were, a few millimeters undersized or vastly undersized. And it's an area where maybe some sort of more of a deep dive would be helpful. But I think it's a great point you bring up. So that's why.
Yeah, and the issue regarding saccular nature is one that will be addressed in an upcoming registry revision.
Awesome. All right. Okay, same thing for TEVAR. Reporting TEVAR sac diameter is much more difficult. Folks get TEVARs for many different reasons. And the surveillance is, I guess, a little bit more challenging because you have to get a CAT scan. I don't know exactly, to be honest, why we only have 40% sac diameter reporting for TVARs compared to 80% for EVARs. But this is what it is. I don't know. We can all do better on diameter reporting, I guess. Oh no, wait, I'm confused. I'm sorry. We're 80% at actually following guidelines for repair and being ethical interventionalists, but we were only 65% for sac diameter for EVARs, and we're only 40% for TVARs. So nonetheless, keep doing a great job, but please write down a little bit better what you're doing in surveillance. I was going to turn this over now to Chandler to talk a little bit about open AAA repairs. And this also is pertinent for suprainguinal bypasses. Notably here in our region, and this has been pretty consistent over time, the observed rate of in-hospital mortality for elective open AAAs is 8.2% in our region compared to 4% nationally. And even when we try to adjust for observed to expected, we're still, way above the mark. This is what the graphic looks like, pictorially. And so you can see, in our region, we kind of bounce up and down a little bit, but this dotted blue line is the 4-year rate, which is what gives us the 8.2%. And that's concerning, has been consistently concerning now for a number of years. Chandler, you want to jump in?
Yeah, I'll just spend a few minutes. It's something that I want to thank Lila for all the work that she's done in terms of trying to crunch these numbers and provide data. It's been a little bit more difficult than I thought working through. Obviously, when you see that we're double the 30-day mortality, it's concerning. I think we have a lot of good hospitals and surgeons here, so there has to be some rationale. It appears that it's probably maybe a multifactorial sort of rationale. We've been looking at some of the preoperative optimizations, and there's some variety there in terms of especially in cardiac clearance and things of that nature. We've also looked at center volume versus surgeon volume and actually trying to match, are there high volume surgeons at low volume centers? What's the difference? And we're still trying to work our way through that aspect. We do see some comorbidity differences at some of the larger tertiary care centers versus not. But I think there's a lot of opportunity that we're really trying to glean here, especially with the intimate environment of being in a regional kind of quality network. There are some questions, especially if it comes down to, is it experience in terms of what a center is doing now, or is it the global experience with knowing that the numbers of open aneurysms are dwindling for our trainees? Is this an issue that we need to address? And so I hope everybody would be willing, if we can nail down on some things, to maybe answer a few questions on some surveys. And I know everybody hates surveys, but sometimes we can get some better information that are not discrete data, especially for post-op care. And that's why I'm excited about this ERAS lecture about how we're doing things in our centers across our region, because I think that we can gain some information that would really prove useful in saying, well, what's mainly the most important factor that we should focus on when we're doing these cases, and how do we really turn this needle? So there'll be more information to come, and I appreciate everybody's indulgence and patience with this, but we are working through it and making some strides. We want to make sure the data we bring you is good and can really push us in a direction and make some meaningful change.
Yeah, thanks, Chandler. I think this is really super complicated, and if it was as easy as doing one simple thing differently, we would have figured it out. We all would be doing that thing. And so I think you're totally right that it's probably multifactorial, but there's certainly things that we can all do better and lessons we can learn. And I'm completely biased about ERAS, and I love it. But I think that's one of the beauties of ERAS, is that it's kind of a global way to rise up everybody's ability to take care of the patient, all the way from like the pre-op anesthesia testing through to like the post-op nursing. And especially in these times when it's just getting so freaking hard to take care of patients, with all of the staff turnover. I think it's going to be a continued struggle, and thank you for helping us figure out where, we can best focus our efforts to work on this. And you can see though, I mean, even though AAA is a relatively low volume operation, there was 12 centers in our region who participate in this module. And 8 of those 12 did at least 10 cases and completed the long-term follow-up data for those cases. And so, we do have a number of high volume centers across the region who are participating. It's a little tough, like UNC, for instance, does not participate in this module just for financial considerations. We are only limited to a certain number of modules. And so, we track our own aortic outcomes, but it's hard because it doesn't get combined into this data. And I'm sure that there's a lot that I can learn from you guys. I will tell you, I'll air my own dirty laundry that when I do a suprainguinal bypass, my AKI rate is higher than the national average. And I don't know how to change that. So if anyone has any advice, if you're one of these people with the 0% problems, call me afterwards. Okay. Everyone's using Cell Saver. That's totally in the clinical practice guidelines, and we're doing it. So thank you. That makes a big difference. Here we are, awesome at Cell Saver. And everyone is doing a really technically good job at maintaining the iliacs. So this is making sure that you maintain flow to at least one iliac, to one internal iliac artery in your aneurysm repairs. And thank you for being awesome surgeons. All right, shifting over now to PAD and infrainguinal stuff. We've done a lot of breaking this down in terms of the reporting between claudicants and people with CLTI and endo and open. And so it's going to take a little while to get through all of this. But the one thing that I want to highlight that I am just like so thrilled about is here for patients who are getting peripheral vascular interventions for claudication, almost 90% have an ABI or toe pressure assessment ahead of time. It is a little bit mind-boggling to me that, this is just because of the way I was trained and because ultrasounds have been ubiquitous, I guess, for the time that I've been in training and in practice. It's a little bit hard to understand how you could take someone for a peripheral vascular intervention without knowing they have an ABI or a toe pressure that's abnormal. And it turns out that 25% of people are doing that in our country, but far fewer in our region. I know that a lot of people, when we talked about this some years ago, said that they were actually doing it, but it was a reporting issue. And, some people did not have the ability to do inpatient ABIs just based on how their peripheral vascular lab setup was. And so they had other kind of proxies. But this number has increased a lot for us from about 75% to almost 90% over the last 4 years. And that means that a bunch of you have really made a dedicated effort to practice best evidence-based practice and care for PAD patients, which is super amazing. And amongst the best in the country here. You can see we're far onto the left side of this chart on the bottom, and it's statistically better than the mean. And 14 of our 16 centers who are doing this module participated in this data, and pretty much all of you consistently are doing very well. Same thing is true for the care of CLTI patients. This is complications for people who are getting infrainguinal bypasses for CLTI. This complications is in-hospital deaths, graft occlusions, reinterventions, and major leg amputations. And our complication rate is just 4.5%, and has been consistently that, about the same as the national average or slightly better for a number of years. So again, humongous congratulations there.
And Kate, can I just add to that, that we had the chance to look at some internal data comparing some of our hospital case index numbers based on region and other peer institutions. And when I looked at the hospitals in our region, I mean, we have a higher, comorbidity rate and case mix index. And so to have a major complication rate that's lower than the national average, especially when we're in the amputation belt or the PAD belt or however you want to refer to it, I think major kudos. And so I think that's a big accomplishment that we should really celebrate.
Yeah, no, I 100% agree. And, especially with CLTI, it's certainly your technical skill in the operating room, but it's also just all of the painstaking effort it requires to coordinate with podiatrists and wound care centers and endocrinologists and everybody else, and building those networks and maintaining those networks even through a pandemic is pretty amazing. Now, we're not quite as amazing for the suprainguinal bypasses for patients with CLTI. And here are major complications. It's the same. It's in-hospital deaths requiring leg amputation or graft occlusion. It's 11% compared to 8%. And when you look at it over the last number of years, we had been kind of bopping a little bit up and down, similar to national average, except over the last 2 years, we've bumped up and now bumped up again with higher complication rate, up from about 5% to 11%. And so when you look at the breakdown here, there's fewer centers doing at least 10 cases compared to the infrainguinal work. And I think that makes sense. This is a less common operation for sure. And, this one center here on the right-hand side has a 30% complication rate. And that's probably just the difference of a couple of patients, one way or the other. But it's something that I think we all need to be mindful of. And it also, I think, is related to the issues that we're having with in-hospital death with our elective open AAAs. So keep that in mind as we progress through the meeting the rest of this morning. For those of us participating in the amputation module, we're doing an overall good job in line with national average in terms of postoperative complications. These complications are different. It's more medical complications that are measured here. So MIs, arrhythmias, CHF exacerbations, kidney complications, respiratory complications, and then also surgical site infections or wound breakdown. And we're kind of, bopping along at about the same as the national average, slightly better this year. There's only 4 centers that participate in this module in our region, though. And so it's hard to know exactly what all of us are doing, but I'm just going to assume that everyone's doing a phenomenal job because we're taking really good care of CLTI patients in general. So keep up the good work.
If I could add something to that,
yeah.
I'm sorry to kind of crow a little bit. We
No.
had a problem. We get a lot of palliative amputations, and so we saw an uptick in mortality following these cases. I know that wasn't one of the high things, and so we're trying to redirect some efforts to make sure we make better decision making with our high ECMO volume and things like that. We get a lot of limbs that come in ischemic, and sometimes we do a palliative amp and they pass away anyway. So that's probably an area that we're contributing negatively to our region, so I apologize, but we are trying to find ways to work on that. So I just highlight that as dealing with those palliative amps sometimes can be an issue.
Yeah, and I think that when we're looking at what counts as a complication, it's all of these medical complications, which obviously in the case of the ECMO patient at Duke, and I'll take a moment to say that the first time I was on call as a fellow at Duke, I got a call from the TICU about an ECMO patient with a blue leg. And I was in the middle of the hallway and I didn't write down the room number. And I finally make it over to the ICU figuring how the heck many people can be on ECMO with a blue leg. Turns out that there was a lot. It's just that some were light blue and some were dark blue. And it is a real thing that you're dealing with, Chandler and Lila. But you'll notice here that death is not here included in the post-op complications, because I think that a palliative amputation in a dying patient is sometimes the right choice, right? Leg amputation is not always a failure. And sometimes, you know, getting the pain control is the thing that's most important for the patient's kind of end of life goals and plan. And a lot of times these patients have unstable situations, and the amputation is not necessarily the thing that makes it worse. And I think, you know, having a high, you know, complication rate here is probably an okay thing, as long as we're not deviating too far one way or the other in comparison to the rest of the country or ourselves over time. Okay, dialysis access. In general, the percent of patients who are getting primary fistulas in our region is 76% compared to 82% nationally. This is not including endo AVFs, but just standard operative dialysis access. And, you know, we've been pretty consistent over time with that. There's only a handful of us who are participating in the dialysis module. But those who do participate are doing a lot of cases. And this one center here is doing 95% fistula first, which is pretty remarkable. Okay, IVC filter reporting. This is someplace where we're doing kind of a crummy job with the documentation compared to what I would expect, just based on how good everybody's documentation is overall in our region. And also kind of crummy compared to the VQI overall. And so for, you know, there's plenty of times you put in an IVC filter that is intended to be permanent and to not come out. But it's important that we record that. And so when you look here at the specific information, we recorded, you know, 123 filters went in, but 78 of those did not have any follow-up records. And of the people who had the follow-up records, you know, you can say that either the filter was attempted to be removed or couldn't be moved, or it wasn't clinically indicated for it to be removed. But here, the percentage of filters not retrieved because no follow-up record was created and no thought was given to it, at least in terms of how we document our thought process in the VQI, 63% compared to 17% nationally. And so even if you're not taking it out for a reason, please document the reason in the VQI record if you're participating in this module. And then, you know, it's a really important quality and potentially medical legal thing to try to remove filters that have been put in and are not needed as permanent filters. And so this is an area that we've just been kind of like steadily declining in pre-pandemic, and I can imagine post-pandemic, it's probably not going to be much better. There are only 3 centers participating in this. And, you know, it's hard to know what the rest of us are doing and what our process is for making sure that we're actually retrieving filters. I know that UNC does not participate in this, but I cannot imagine that we're actually doing that much better than the data that we've got here. And so this may be something that we put on the back burner. I think it's more important to focus on aortas for, you know, our quality initiatives this next year, but we shouldn't forget about these filters. And that, my friends, is the updates of all of our data. So overall, phenomenal job, and we'll do a little bit of focusing on aortas, which I think should be our quality improvement thing that we do for the next year. And we talked about it a little bit the last time, but do any of the rest of you want to speak up and add any other things that you're concerned about or care about or want to bring to our attention? All right, we'll move on then. I don't think that Tom could join us. Betsy, do you just want to jump in for him and give the Arterial Quality Council update?
Absolutely. So for the AQC, there was discussion in regards to the new national quality initiatives, the discharge medication, as Dr. McGinnigal shared, we're, pretty much as a nation, we're doing really well. And so there's discussion about placing this into maintenance mode, which is, we've got great compliance with that. However, on our EVAR SAC diameter, we still need to work on continued efforts to improve our compliance. We also discussed National Long-Term Follow-Up Survey creation, which I did, and the results. You can see everything on www.vqi.org in regards to that. You can also still take the survey if you'd like. There's discussion on VQI risk calculators that are being developed, and you'll actually get to see a sneak peek at VQI Advan this year. We're super excited about those. And also we're trying to improve our harmonization of urgency variables as much as possible across the like registries. So that's a work in progress. And that was pretty much it for the AQC.
Excellent. Dr. Sheehan, are you on? Would you like to tell us about the Venus Quality Council? Oh, I thought she was coming. Betsy, have you seen her on?
I don't, but I thought she was coming also.
Yeah.
That's okay.
Okay.
We can keep going. So for the VQC update, we created a separate Venus rack. They actually had 3 proposals for 2021, and you can see those topics here. Oh, she's having problems with her audio. Oh, I'm so sorry. You can see those 3 proposals there, and they were excellent proposals. They had an AVF meeting February 23rd through the 26th, and as many of you know, the Venus Registry, they don't have metrics right now. So they're discussing topics and ideas to implement for metrics. They've discussed anticoagulation after venous stents, C2 disease for varicose veins, IVC temporary filter retrieval. And if you have any ideas, if you could reach out to her, that would be fantastic. I think that was it for the VQC update.
All right. All right. Dr. Genovese, I know you're on. Whoops, sorry.
So not a whole lot to update from our side of things. Just want to encourage, I know we're about to talk here in a second about, aspects of a good proposal that kind of will streamline you guys through for getting your projects approved. I just want to reiterate that, I personally am always here to help anyone who wants to run an idea by me, or I can help with the abstract, the proposal creation and editing and things like that to kind of help boost the success of getting that through. And essentially the racks are looking at to make sure that the question that you want to ask is something that can be answered by the database, and it can safely the data can be safely given to the investigator without compromising the anonymity of the institutions who participate, the industry that participates, and particularly patients that are in the database. So I'm happy to help anyone. Just moving forward, if you do happen to have data from a prior proposal, just want to remind everyone that it is important, even if you want to ask a different question with the data you already have, you do need to resubmit the proposal. We are going to be keeping track of papers and things like that that are published, and making sure that they have actually gone through the RAC and have been appropriately approved. And this is just to, again, make sure we're creating a safe environment where the data that's being talked about and published and analyzed is not violating the privacy and anonymity of the participating institutions. So if any questions, please feel free to reach out to me. I will put my email in the chat box, and more than happy to help anyone create a project proposal if they're interested.
All right, Dr. Murby.
Alrighty then. So, speaking to some of what Liz said, we've actually started creating some videos on how to successfully create a RAC proposal. So, and to a couple of points, the main purpose of the RAC is to ensure that the question can be answered. And also remember that a PSO is slightly different from a generic registry, whether that be STS, NCDR, or NSQIP, that there are additional protections that need to be observed regarding things like unblinding and how the data can be used. So we just make sure, so the videos, they're short. I think one of them's up at this point, basically walks through submitting a proposal. The main things on the proposal, or the most common things we see missing from proposals, are the sample tables, co-investigators' bio sketches, and bear in mind, the application doesn't need to be long. It just needs to be complete. I will also add that we're hoping that, I think one of the things that will come out of the new training program called the FIT program, and Betsy can speak to this extensively as she's been integral in its creation, is as we train some of our more junior community members, that the whole level will rise up.
Yeah, absolutely. We've got a little bit of information about the FIT program at the end of the meeting, and I'm really excited about it, and should give kudos to Duke, because Mitch Cox, who's actually leaving Duke, but he put together a proposal with one of the trainees to do some of this, quality improvement and VQI research work. And hopefully, even though he's transitioning, you guys can continue to, to promote that project. Now, before we move on, Dr. Brothers put in the chat a question about the lower extremity amputations. And he asked, does the amputation complication include re-amputation or wound breakdown? Obviously, if you have a higher rate of AKA to begin with, then you'll have a lower rate of reoperations versus centers who are trying to preserve BK as much as possible, even if you need a few, re-amputations or debridements related to ischemia. And so there's a trade-off to try to get the more functional amputation at the risk of greater need for conversion to a proximal amputation. And so just to clarify this, the complications include surgical site infection of the stump, but not reoperation or converting from a BK to an AK. And so that trade-off shouldn't really be included in the complication rate. The complication rate's really just for surgical site infection, and then the rest of the complications are related to medical comorbidities in hospital, worsening of those. Okay. So circling back around, there's been a lot of, work done with VQI data, and thank you all for, putting in the data for your own quality purposes, but then also so we can get this information out across the country. And so here we've got listed the top 10 VQI publications that are really from a wide variety of pathologies, everything from endovenous laser ablation to carotids, to percutaneous brachial access, quality improvement programs for AAAs, EVAR screening, pandemic effect on COVID, and different outcomes for CLTI patients who are the very elderly. So take a look at these papers. You'll get all of this in the minutes. And thank you again. And then just to reiterate what Dr. Genovese said, those of us who are at academic medical centers are a little bit, more automatically plugged in to being able to, design research questions and have access to epidemiologists or statisticians to help with the data analysis. But that doesn't mean that the rest of you can't ask questions and can't participate. And I know, just Liz Chandler and I, all three of us, would be more than happy to help facilitate and participate. If you have a trainee coming through who has a question, or you know, you yourself have a question or something that you've always thought about and you want to talk about at a meeting, but you don't necessarily, you know, have the bandwidth or to get the data. And it takes time and it's not easy, but it's maybe a little bit easier for us just because it's the practice that we're embedded in. And so we're happy to help. Not to mention, far too many of these papers are from California and New England, and so we should step it up a little bit. Okay. Oh, here's more RAC information. I'm sorry, Liz, I got a little bit out of order, but do you want to just talk a little bit about actually putting a RAC proposal together here? Oops, you're on mute.
Okay, can you hear me now?
Yeah.
So, a couple of questions that we're trying to answer when we're looking at RAC proposals. The biggest one is the question you're answering able to be answered with VQI data? And so we just want to see that there's a thought out process with regards to what your question is and how you're going to use the data to answer that question. So on the M2S website, there is data dictionaries for all of the modules. So you can pull up those variables there. And essentially what you're going to do is a research proposal. And this will actually help you with your subsequent manuscript drafting and your abstract drafting and things like that. So it's not in any kind of a waste. So it's a introduction, introducing the question and hypothesis you're going to answer, example data tables and figures, and this does not have to be populated with actual numbers. This is just examples of, are you thinking about the right way that you're going to answer this question, and then a research methodology as well. Uploading not only your CV, but also those who are going to help you with it, or at least commenting on the support you might get for when you get these large databases, just to make sure that you have the support to be able to utilize this data when it comes to you, because sometimes it takes a little bit of tweaking in order to get it into a usable manner. And then, like I said, we're more than happy to kind of take a look at it to ensure your success, and then ultimately it gets submitted. And it's a every other month cycle where we'll have a deadline, then we'll review them, and then it'll get back to you as well. The other key thing is that you can only get data if your center engages in that module. So if you don't engage in the amputation module, you can't ask for data for that. So that's just one thing to keep in mind. But this is, it's like I mentioned, it's just all to make sure and set you up for success. This is the abstract submission website, and we also have the dates of the deadlines for the different cycles listed there as well. And there's also a list of projects that are approved on there as well. And if there's something that hasn't been published and you see someone has started a project in the recent, in the near future, you can always reach out. We really encourage collaborative projects across different institutions. And I have never heard of anyone being told they didn't want to collaborate with another institution or another provider who's also interested in answering that question. So always, I'm also, free to help kind of make those connections if maybe it's something you're interested in doing as well.
Thank you. All right. Quick, just the governing council.
Kate, I'm sorry. Can I just add something? I put it in the chat.
I'm sorry.
I just want to make sure that everybody knows something, that when you obtain RAC approval, it's for that study, not for the whole data set. So even if let's say you want to look at infections after lower extremity bypass, great, go for it. if you cannot then take the data that you have and look at 5-year patency unless it's in the context of your original research question. So the data use agreement, which is a binding agreement, is for the project that has been approved by the RAC. So just be aware that that is part and parcel of this. And some of this gets to the PSO, some of this gets to, again, we want to make sure that the data can be answered with the data that is provided. Sorry to interrupt.
No, not at all. I mean, that is really important. And, you know, especially in our region, you know, a lot of you toil away at putting in this data and use it, you know, for your own QI purposes, which is of course the primary goal of the patient safety organization. And, you know, the academic side of this really has to, you know, hold itself to a pretty high integrity bar and not misuse your data, and certainly, you know, never be in a situation where it would be de-identified. And of course, we take all that very seriously. Okay, at the Governing Council meeting, the thing that we were all most excited about, well, I think that we're excited about a lot of stuff, I won't lie, but I think we're all most excited about Dr. Lemon providing an update on the VQI Fellows in Training program. And this is something that any trainee, whether it's a general surgery resident who's interested in vascular, or a vascular trainee, whether they're a resident or a fellow, can find a mentor either at their hospital or elsewhere. And they develop a question in a QI project and get to have mentorship in how to create this project and study it and implement it, not only at the individual center level, but also then with programming that's done, you know, with all of the fellows from a national level. And it really helps with networking and building academic credibility in our trainees, whether or not they're going to go into academics or private practice. It shows that you know, are able to do a project and see it to completion, and you've got administrative skills that you can then, you know, use in whatever capacity as you go out into practice. And so this is really, really, really great. And I think that it will help prioritize a really strong legacy of, you know, continuous quality improvement. We also had some input on different software development activities, and we're in the process of updating a lot of the different registries and trying to harmonize the variables a little bit more. There is going to be a device assist integration with the peripheral vascular module, such that it'll be easier to get the devices inputted into the registry. And then there's also going to be those people who get long-term follow-up, but it's out of the standard 9 to 21 months long-term follow-up window. You can still record that and get credit for it, but just have it marked as kind of out of window follow-up. And that will help us have a better sense of what's actually happening to our patients that we operate on, and I think will be helpful just in our local, you know, QI efforts. Dr. Jorgensen has spent a lot of time with the FDA and discussing type 3 endoleaks and trying to figure out some of the issues with the endologics, AFX. The FDA wants better long-term surveillance for the devices. And we're developing relationships with industry, and they will actually be charged in order to use our data and our long-term data. And so that will help support data collection and standardized data collection methodology for the devices that we're implanting. And they're going through the process of kind of determining what those details will look at. But this is a way that we can leverage our industry partnerships and have our data used for long-term surveillance data and get more support from them. And then we'll also be able to take a lead in more of the long-term surveillance and also information on risk calculators and the type of risk calculators that should be used and how they should be maintained and how they should be developed. And all of these will be housed all together on the website. So it'll be a little bit more clear which risk calculators perform the best and are the most useful for the type of patient. The ones that we currently have estimate mortality, short and long-term mortality well, but a lot of the other, risk of MI and other short-term complications are not as predictive. And certainly if you go out and use the more general risk calculators like the NSQIP risk calculator, it's not that accurate for our patients. And so that's another big initiative that the national level VQI is working on. All right, so we have done tons of talking and we have blown through this agenda faster than scheduled. Dr. Spangler is here and will give her talk. It was not scheduled to start until 10:30, but since it's only 10:07 now, do you guys want to come back a little bit early just in attempts to finish up everything early? What do you all think? Chandler is nodding his head yes, and I'm going to assume since he in general has good taste, he's speaking for all of you. Now Liz is nodding her head yes, she has better taste than Chandler. Okay, good. Okay, we'll see everybody back at 10:15.
Kate, just to clarify, should I share my own screen for the slides, or do you guys do it from the?
I'm happy to do it for you. I kind of prefer having control, and in that way you can be on like presentation mode. So do you want me to stop sharing and you can start sharing?
Sure, that would be fine. I added, after some of the kind of questions to get feedback on what people are at the end of the presentation, I also have some individual resources that I can pull up from that. I'm not sure how that best fits in with your break, but some people had approached me about particular questions for the protocol, and I just wanted to show them what some individual institutions have made.
Cool. Yeah, no, that's great. I think the more the merrier. I think a lot of people have a lot of interest in this, and we've got lots of kind of breakout room time and then debrief time all around ERAS. And so if you're available to stay for some of that too, that would be wonderful.
Need a little longer time for the breakout rooms, Dr. McGinnigal, that's fine. I did
better to pull it. We'll do the breakouts, but then pull everybody together.
I do want to let you know, of course, Ring Central, we've had some trouble arranging for the breakout rooms. So you're going to have to assign you a room. Again, this happened last fall where we couldn't assign Chandler. So we're going to leave Chandler in the main room. They've assigned me to a room. So Lila's going to have to call in with me. So I think it's a Duke firewall. That's what we've determined. So because it was Chandler and Lila that we couldn't assign. So anyway, so we'll announce that, but Chandler will stay in the main room instead of you. We've assigned you a room and then assigned me a room, and Lila will be with me via phone. And it'll be you a room, and then Liz Genovese, she was able to be assigned. So, but Jen will let us know. I just wanted to let you know we had to redo that. So sorry about that.
But I guess we have to do in-person meetings, right?
I know, exactly. So, but Jen will explain which rooms, and she was able to assign everyone else. So we're good.
Perfect. All right. All right, it is 10:15, so we will get back to it. I have the distinct pleasure of introducing my friend and colleague, Dr. Emily Spangler. She is a very accomplished surgeon and researcher who is now practicing at University of Alabama. But before that, she was an undergraduate at MIT, and then she went to University of Pittsburgh for medical school, where she also got a master's in science for clinical research. In her current practice, she focuses quite a bit on clinical outcomes research and effectiveness evaluation. And most recently, she's participated in the Enhanced Recovery After Surgery group of the Society for Vascular Surgery and the ERAS Society, and was one of the very important co-authors for the recently published ERAS in aortic surgery guidelines. And I will let you take it from there. Emily, thank you so much for joining us.
Thank you for having me. It's great to see so many faces that I know on the call today. And as Kate mentioned, that we're going to talk a little bit about ERAS and the transition to vascular care. So this meeting group is probably well aware that surgical outcomes reflect more than just our intraoperative care, and that ERAS pathways have been applied throughout other aspects of surgery. You've probably heard about them mostly from colorectal as sort of initiating group, but they've been associated with decreased length of stays, as well as potentially reduction in care disparities. So for this talk, I'll go over a little bit of the history of ERAS and what those principles are, and then speak more specifically on our guidelines that are informed by published literature on aortic care. Kate didn't mention yet, but that we're also working on more of a white paper about recommendations towards lower extremity care, but both for lower extremity as well as amputation, we've not quite reached an evidence base to be able to make more of these consensus guidelines at society level yet that would meet the evidence threshold for ERAS pathways, although there's very active research from a number of groups nationally and internationally towards those. And there have even been updates in literature since the evidence base that we use for our aortic guidelines that continue to show that this is a promising pathway forward. So in that regard, it'll be a little bit of hypocrisy in that I'm presenting on published guidelines, but not necessarily protocols that I've used individually in aortic care yet, but basically showing the evidence for what we have to help build these pathways forward, and then talking in more detail at the end about some specifics as we try to build these, about what lessons we can take away from our other pathways that are in place. And really that key that implementation of these pathways holds some local challenges, but also some opportunities for us both as individual sites as well as a society and a quality group. So for the history of ERAS, these concepts are not necessarily new, but in the literature, you'll find that people cite that it takes about 17 years for things to get from a published state of research efficacy out to dissemination in the community. And so we're a little bit behind still, but the concept is that by modifying components of the surgical stress response, you can improve recovery and reduce postoperative morbidity. This was formalized a little bit more on the colorectal end around 2001 with a formal study group and largely based in Europe. And then the consensus protocol for colon surgery started in 2005. And the idea is that looking across the arc of care, starting with preoperative information and teaching, attenuating aspects of the surgical stress and pain and mobility aspects around surgery can lead to better postoperative physiology and recovery, as well as potentially satisfaction for patients. This then expanded from those initial protocols out to other parts of colon and rectal surgery and was formalized into a nonprofit medical society in 2010. And since has had expansion through other surgical specialties, notably hepatobiliary, urology, OB-GYN, and then vascular being a little bit late to the party, most recently with our guidelines that are in the online publication and should be coming out in JBS later this year. The ERAS Society is also working on other guidelines towards emergency surgery, most notably coming up, and then has less disease process specific, but general resources for anesthesia, nursing, and other allied healthcare providers available on their website. And the idea is that this is continuing on the spectrum from preoperative through intraoperative and postoperative care, beginning with things like appropriate pre-admission risk stratification and patient optimization, as well as education and expectation setting, attenuating the surgical stress around the procedure itself, and then helping to maintain postoperative physiological functions. I wanted to comment briefly about the terminology used. You may see ERAS, ERP, and Fast Track thrown around a little bit. ERAS, and you'll notice probably the trademark along this during the course, that means that the ERAS Society, formally internationally, has endorsed the statement or protocol with their review. ERP is kind of the term from most of the more recent in-house developed pathways, in that it's an enhanced recovery protocol aiming to mitigate some of these perioperative stressors, but not necessarily endorsed more broadly by a society. So it may have some elements that align, some that are more program specific. The Fast Track is used in much of the earlier literature and was even in many of the protocols that eventually became formally ERAS endorsed. Sometimes in them, however, there wasn't as broad of a conceptual plan. It was more, can we do this faster, rather than necessarily, instead of focusing on the speed, focusing on the quality and the attenuation of stress to therefore elicit an enhanced recovery. So sort of the idea of taking a winding road that you're trying to navigate faster and making it a more smooth transition where it's easier for that process to occur. So within our specific SVS aortic guidelines that were derived from a literature review and grading of the evidence, and then consensus among surgeons, anesthesia providers, both nationally and internationally, as well as additional allied healthcare professionals, that we're starting and looking at this arc of care from the pre, intra, and post-operative phases. In the early pre-hospital phase, a lot of counseling and education to both set goals and expectations and improve understanding by providers, patients, and other caregivers, making sure the patient's adequately optimized coming into their surgery. This is primarily focusing on elective and non-urgent conditions, but can be used in part for other things that do have more urgency to them. And then considering aspects that haven't necessarily traditionally been encompassed in preoperative care, like frailty and delirium screening. And then looking at more around the time of entering surgery itself, of avoiding some of the stress that comes with prolonged fasting, both in terms of glycemic impact as well as fluid balance. As we get more towards the intraoperative phase, focusing on making sure that we're providing optimal care in terms of fluid management, antibiotics, normothermia, pain control regimens, and nausea control regimens. And then postoperatively, making sure that aspects that can be optimized in terms of mobilization, return to enteral feeding, and just daily tasks can be continued on a structured pathway forward, so that there's less variation in care, and that patients are knowing what's in store for them as well. And throughout all of this, with the recommendations to make sure that we're assessing what we do and the corresponding outcomes from that along quality improvement cycles. So the specific recommendations are outlined in the publication that I'll list the reference for at the end, but there are aspects of it that I would say are less controversial and potentially more controversial to people based on what they were historically trained about or may have considered. So in the pre-admission phase, looking primarily at risk factor screening and risk factor optimization, there isn't as much that is novel at this stage. These are all pretty widely held recommendations that we had a strong grade of evidence for, with the exception of prehabilitation, which is a newer concept. And again, has some early evidence base for it, but the evidence is low in vascular specific populations so far. A lot of these other aspects as well may not have vascular specific evidence, but among considerations for anesthesia and cardiac risk have good evidence in broad populations to make sure that anemia and nutritional deficiencies and tobacco and alcohol use is managed appropriately beforehand. That particular to our vascular patients, just more explicitly stating also that aspirin should be continued throughout the perioperative period, and then stopping antiplatelet medications and anticoagulations before surgery, except in select patient populations, should also be considered. And this is more specifically in part for some adjunctive pain medication maneuvers that we recommend around surgery. So in the more immediate preoperative and perioperative phase is where a lot of the newer concepts related to limiting the stress response and improving pain control are introduced. Most of these, unfortunately, so far have to be abstracted from other ERAS protocols of major abdominal surgery, which are largely GI based. In the future, as more of the vascular aortic fast track pathways and enhanced recovery protocols within other aspects of vascular surgery have more time to gather evidence, we're hopeful that the evidence base can be validated among vascular patients or refined more specifically to our patient needs. And in particular, the ones that get the most attention are limiting the duration of fasting, considering carbohydrate loading, and multimodal pain control. So in particular for fasting, what we're talking about is avoiding overnight fasting to encourage clear fluids for up to 2 hours before and light foods for up to 6 hours before the induction of general anesthesia. For carbohydrate loading, that we couch this as with patients without diabetes should receive a preoperative carbohydrate drink. Vascular patients have a greater prevalence of diabetes than a number of populations in which the carbohydrate loading was studied previously. So that's definitely an area where we can't guarantee that it's indicated in vascular patients, which is why it's absent from those recommendations. But that the basis for this and what they're talking about is 800 milliliters of a clear 12.5% carbohydrate drink the evening before surgery. So talking about things like Gatorade or Powerade, and up to 400 milliliters within 2 hours before surgery. The thought is that that carbohydrate loading reduces postoperative insulin resistance and leads to less perioperative hyperglycemia than those that either had placebo or NPO after midnight instructions to them, and that what we're doing is modulating some of the inflammatory and metabolic response around surgery itself. So again, something that is probably pretty different from what most of us practice day to day, unless we have very ERAS forward anesthesia teams. But an important part of what other guidelines have suggested are needed. And then in addition, for medication therapy, a heavy emphasis in mitigating that surgical stress response on multimodal pain control and nausea and vomiting prophylaxis. And so here again, focusing on things like acetaminophen, NSAIDs, and gabapentinoids as part of the multimodal opioid sparing anesthesia strategy that can allow enhanced recovery and less concern of issues like ileus. And there is a caveat among these that for issues especially of NSAIDs and gabapentinoids, that consideration of age and renal functions might mitigate how you employ some of those agents, that we're not recommending these at the expense of patient safety, but more in patients who are able to take them, that this can help spare some of the opioid need around surgery. And encouraging a strong consideration in aortic patients of epidurals, and in other ERAS protocols, a heavy emphasis on using adjunctive anesthetic blocks. For the perioperative medication therapy, DVT prophylaxis and antibiotic prophylaxis, antibiotic agents being a pretty standard regimen. Venous thromboembolism, even among our group, we did have a little bit of debate about how preoperative DVT pharmacologic prophylaxis might be employed. And some of it has a caveat to, if the consequences of bleeding are thought to be serious, then that could be delayed until the risk abates postoperatively. In vascular patients compared to other patient populations, we don't know as much about how the intraoperative heparin may impact the DVT risk, but there's observational data from VQI and other institutional sources that major aortic surgery still does have a significant VTE risk, for why that recommendation is strong, but of moderate data quality, with some of it coming from other sources. And then in terms of intraoperative course, general recommendations for anesthesia to be giving neuromuscular blockade, and to be using invasive cardiovascular monitoring to maintain appropriate MAP ranges, and to aim for euvolemia, use of cell salvage, And then that for surgeon specific, that routine use of things like phendolepam or mannitol for non-suprarenal clamping does not really have a great evidence base for it. So nothing too scandalous in the intraoperative recommendations. That we are strongly in favor of epidural anesthesia as a way to mitigate the pain response and opioid needs around time of surgery, and that is not something that seems like it's significant limitation to ambulation or postoperative recovery, but can actually facilitate that. That otherwise maintaining normothermia and avoiding use of drains can assist with the postoperative recovery as well. And then again, in the postoperative period, a few recommendations that might raise a few eyebrows. Continuing the use of multimodal analgesics may be a shift for some people, but is recommended as we're gaining awareness of the impacts of opioid consumption. To consider removing the NG tube or avoiding routine use of it for after surgery is one that has basically not shown adverse consequence in ERAS protocols that are focusing on the hepatobiliary system, and that since we're not disrupting the actual GI tract in most patients, there's good evidence that the time for gastric recovery after surgery is around 17 hours, plus or minus maybe about 8 hours. And so the thought of intentionally having to withhold food or continue to actively drain the stomach in that period afterwards has less evidence for it. And the fast track protocols that have been out of Italy and other international sites have not shown prohibitive issues in terms of returning to normal diet or being without an NG tube in those cases. For fluid therapy, part of this is, again, conditional on having limited the volume deficit during the preoperative and intraoperative portion, but to avoid excessive fluids in the postoperative period and to restrict the fluid therapy to about 1.5 liters per day maximum if they're coming out euvolemic. Again, if there's reason to believe that their volume basis is not appropriate with that, that indications may change, but this is more for anticipated recovery. And then again, urinary drainage, early removal of urinary drainage catheter recommended when not having another need for them. We talked a little bit about in cases of the epidural being continued, of whether that is a reason that urinary catheters may need to stay, and overall the evidence basis would suggest probably not. Overall, only about 10% of urinary catheters would need to be replaced for issues of retention while the epidural is still in place, with that number being closer to maybe 25% in patients with BPH. So clearly some of these therapies may be needed in certain cases, but an overall emphasis towards discontinuing them earlier and doing without them when they're not. And again, maintaining appropriate glycemic control in the postoperative period. Early mobilization is additionally recommended, and key to this is not having it be ad hoc, but having a formal plan for early mobilization between nursing and physical therapy teams. And this can begin with even things like sitting to the side of the bed or having supervised first ambulation to grade it on a scale and documentation that's being done. And then towards discharge, making sure that there's written and verbal education, and some of this discharge education often is even incorporated into the preoperative education for patients in terms of knowing what to expect and appropriately following the patients in the postoperative period. And then finally, just a reminder of auditing the outcomes. We've set these criteria as things that have good evidence base, but some of that is in flux, and that I would add that other ERAS protocols, our institution's colorectal ERAS pathway several years ago found on audit of outcomes that they were having unusually high rates of AKI compared to what other institutions were when they looked back through. Part of the way the order set was delivering additional doses of NSAIDs was basically stacking doses from the end of the OR case to the early hospital course. And it was something that they found that they needed to modify their local protocol to avoid patient risk. So continuing to audit outcomes is something that will need an infrastructure and is very important. Just like everything else, we check about our own outcomes within VQI already. So that's a lot. Some of you may be kind of grimacing in the background and saying that half of that sounds stupid, half of that's what I already do. Not all recommendations have aortic specific evidence base available. So there are things that we sometimes do because it's reasonable, but that we don't have an RCT for. And as I mentioned, for issues like removing the NG tube at the end of the case or in the early postoperative period, we're extrapolating, but from types of surgery that should have similar impact. The uptake overall does not need to be all or nothing. Even if there are only some of these things that you think are improved, incrementally reducing the surgical stress, especially focusing on some of the preoperative and intraoperative adjuncts, can help with the ability for improved outcomes to flow from the rest of it. So there is some evidence in the other ERAS protocols that increasing compliance in terms of number of elements used was associated with decreased complications and length of stay, suggesting that, that better overall use is of benefit to patients. And so then, you know, this isn't something where you just flip the switch and it happens magically tomorrow. One thing that I just wanted to briefly comment on, especially that I'm sure that many of your institutions are going through nursing shortages and everything else, is that there has to be an organizational readiness for change and an infrastructure ready to support this. So there may be cultural aspects, you know, in terms of setting up ERAS programs at the VA. A big challenge we've had is that we don't have an anesthesia team that feels comfortable with doing blocks. And so that poses a major challenge to our ability to move other parts of the protocol forward on limiting opioid use or decreasing length of stay. So finding who is willing and resources to commit to some of these change aspects as a preliminary is important. And then recognizing that this will also need an infrastructure in terms of monitoring and implementation that requires persistence and cooperative behavior across disciplines to be able to reach eventual effectiveness. And so with that, other studies of ERAS protocols have found the existence of the protocol, basically having it available or having an order set, is not enough. Then when they compared institutions in a similar region or a similar hospital system that just had the mechanisms available, but no champion or no auditing done for it, that didn't change practice. And that multidisciplinary care and buy-in is critical, particularly finding champions across the different elements of the stakeholders that are involved, this from the surgeons, the anesthesiologists, the nursing teams, and physical therapy. And even critically in areas where there are trainees, making sure that those who are on the day-to-day care of patients, from entering the orders or selecting the order set or responding to calls, are aware of what the protocol is and how to effectively use it. And then lastly, audit of outcomes. Kate may speak to this further, but that hopeful, just as we've started to look at from the general aortic care guidelines about what our actual compliance rate with those are, of potential role of VQI in assessing ERAS outcomes. I will, as sort of an aside, and can share more details of it later, say that some of the aspects of more the pre-op and perioperative care for things like dietary concerns, urinary tract or Foley removal, those sorts of things actually have a lot of overlap to other ERAS guidelines. So while we have from our institution that has a lower extremity bypass and an amputee ERAS protocol, as sort of a background, while we were developing our individual auditing internally from that, we noticed that our NSQIP abstractor could also look at what the rates of those metrics were by just filling out part of the colorectal form on those patients that were already getting data abstracted from their lower extremity bypass care, to help us know how we were doing with smoking cessation and fluid management and those sorts of things. So there are some mechanisms, but it may take some in-house work until something more formal is developed. So in conclusion, enhanced recovery principles and structured protocols have been successfully utilized in other major abdominal and cardiac procedures to improve quality of care delivered and outcomes. The SVS ERAS documents outline available for evidence in our published aortic guidelines and upcoming lower extremity bypass recommendations that are not formal guidelines, but more of a best practice paper. And this is our document that you can find on PubMed currently and will be coming out in print later this year. So with this, initially I'd like to hear some discussion. I think there'll be some more in the breakout about what things of this are appealing, what might be of concern, and both willingness to adopt as well as barriers to adoption that you foresee. And then I can additionally share some examples of the non-aortic ERP implementation resources that several institutions have utilized to give you a sense of what's out there already. And I don't have the chat viewable on my current screen, so if anyone else wants to verbally chime in.
Emily, thank you so very much for that wonderful talk and great explanation of ERAS, and to take us through all of the very hard work that you did over the last couple of years to put the aortic document together. I think that we will take time to kind of talk about these 4 things in the breakout rooms. And then we'll come together all as a group to figure out what we as a VQI can do to help each other, and hopefully then show in a couple of years a change in our mortality outcomes for our aortic patients. But while we've got Dr. Spangler here, and while her talk is fresh in our minds, if anyone puts anything in the chat, I'm happy to read it out loud, or please just turn on your microphone and ask any kind of at-large questions that you may have.
I had some questions, Kate, if no one else has anything right away.
Yeah, Dr. Long, go for it. And I think Dr. Brothers is trying to ask a question, but he might be having a problem with his mute. So Chandler, why don't you get started, and then Dr. Brothers, you can do the chat box, and I can read it out for you if you'd like.
Well, I just wanted to congratulate Dr. Spangler on an amazing talk, and I thought that it was incredibly well researched and well done. The interesting thing to me is that, at least in my training, you kind of have these mentors who are kind of the gurus in aortic surgery, and they do things out of dogma, and you kind of do it that way all the time. And you touched on a few things that I guess we hold somewhat true here at Duke, and maybe for wrong reason. So like with suprarenal clamping, I tend to give a half dose of the mannitol and Lasix, and that was really maybe drawn from what our transplant surgeons do with kidney transplant, stuff like that. No doubt. Didn't know if that was harmful or just found not found to be very useful per se. The other thing was with regard to the NG tube, pulling early, feeding early. When I've done my cases, if I can keep the bowel in the belly and kind of tuck it away, keep it warm, not lose so much incidental losses, they tend to have really early GI recovery. But some cases where it's very long, we have a lot of incidental losses with the bowel being outside the body, things of that nature. I tend to depend on the NG tube a lot more, and just didn't know if that recommendation was based on operative time, per se, blood loss, per se, other factors that may kind of cause the bowel to be a little more edematous, especially with resuscitation and things of that nature.
Yeah, so getting back to your first question, I would actually say I'm in agreement with you on the suprarenal clamp, and I think that is explicitly mentioned in our text that there is an evidence base for mannitol in a suprarenal clamp that is mostly observational. It's not something that's of an RCT nature, but that it is vascular specific and specific to suprarenal clamps. What is not recommended would be things like ischemic preconditioning, or going to administration of systemic phendolepram or mannitol in an infrarenal clamp. So that was kind of the evidence base that's potentially a little different from what might have been dogma. Certainly renal protective measures when you're clamping above the renals are still important. And then in regard to the recovery and dietary concerns, I think that is something where these are guidelines, and that there's physician discretion that's advised. That, like you mentioned, that when you have a pretty straightforward case, that this is something that's not going to be a challenge. If you have someone that's got known gastric paresis or those types of issues where you have a clinical reason to suspect that that's going to be a challenge, that's cases where skipping that element of it and continuing with other aspects that can mitigate the need for opioids or other things that would delay gastric recovery are still important. But we didn't have any specific criteria of, if it's this degree of blood loss or that you've eviscerated versus not eviscerated for for prolonged periods of time. We haven't said specifics about when that would not be indicated, but just more of a general recommendation to consider taking it out at the end of the case, or if not, consider early removal as you feel is able.
I'll read out, Dr. Brothers added in the chat that he agrees with and uses nearly all of these recommendations, but he's tried multiple times to do early feeding, essentially though always leading to vomiting and nausea.
Mm-hmm.
And I'll let you respond here, Emily, but I think one thing that is very clear is that prolonged use of NG tubes increases your aspiration and your pneumonia risk. And there's a difference between removing an NG tube and then feeding the patient. And what I've developed in my practice is to remove the NG tube at the end of the case. And I'm confident in doing that because the people who do Whipples at my hospital remove the NG tube at the end of the case. But then based on, was the bowel edematous by the end of the case? How good did the anesthesiology team do with maintaining euvolemia? Does the person have diabetes with gastroparesis? You know, was this a redo with a really scarred down duodenum or straightforward? All of these types of things. Even if the NG tube is gone, I still may keep the patient NPO. And that is, you know, potentially, you know, something that we just have to spend years working on and collaborating together to figure out, you know, who can eat the graham crackers and who should be, you know, stuck with just Jell-O. Emily, I don't know if you want to add to that, or Tom.
Yeah, I think the sort of the caveat is access to enteral intake, you know, is still meant to be an as ready by the patient disclaimer. So it may be a few nibbles, a few sips, those sorts of things, rather than outright preventing. But I think that this kind of gets back to me more for conceptually thinking this is what have we done to attenuate the stress response going in. So if we've had, you know, good non-narcotic anesthesia care with a well-controlled epidural, had good euvolemia during the case, those sorts of things that will facilitate early recovery for the GI tract, that then that's a situation where this is going to be safe. If that we're not just advancing food for the sake of advancing food and having rebound emesis from it. So I think that's part of why we have to think of it as a broad union of all these incremental steps that we can make, and that you have to decide what's safe at your institution.
And then Dr. Brothers rebuts that we said resume a normal diet.
Gotcha. I guess, was that the final wording on the
I mean,
on the actual
I can speak to that a little bit, and
yeah, normal diet. I mean,
you know, there's differences on what a normal diet is, right? And I think what this means, and what's been proven time and time again in Europe and in other specialties in the United States, is that when we kind of take a paternalistic approach to diet and we keep people NPO for some set amount of time, you know, until flatus or whatever, and then we let them have clears, really, they may not want to eat Jell-O, but they may want to eat graham crackers, but they won't be allowed to until the PA or the intern rounds again the following day and allows them to have a normal diet. And then when they finally do get their normal diet, some people, like me, for instance, would probably order like a single scrambled egg versus a hamburger. And so teaching your patient ahead of time that they're going to have issues, they're not going to be able to eat like normal, but allowing them to order from a normal diet menu kind of at their own pace tends to be better for like patient satisfaction, and then you don't have the unnecessary administrative delays of like when your team happens to arbitrarily round and change diet orders.
and I think the other thing to recognize with this is that you know, if you talk to your colorectal surgeons or other more established pathways within your institution, that when they have these guidelines, that this is what's happening in ideal care and care that's progressing well, but there still has to be a high threshold for seeing when patients are deviating from that track. And it's not that if they're vomiting, you're going to keep giving them regular food or those sorts of things, that this is to be able to allow them to progress in an enhanced recovery if they're succeeding with it. And that there's always an argument about, if you're getting these patients out of the hospital faster, are they rebounding in different ways? And in most of those other investigations, the answer has been no, they're actually continuing well. But that is with the recognition that if they're not thriving on ERAS, then you may need to taper back on the parts of the protocol that are not working for them.
All right. Dr. Brothers seems happy with that answer. And somebody asked for us to share the article again, so I'm just going to share that.
Yeah.
And this is free access. Can you all see that now? Somehow I've messed up the way my screen is presenting. But the article, if you just type in, SVS, ERAS, aorta, it will pop up, and it's open access for everybody to be able to take a look at it and download it.
And then, actually, Kate, if you don't mind, I'll go ahead and just briefly show before the other room some specific examples towards implementation. That this is them kind of written out, and that I'm going to try to drag over the appropriate part to the screen that will actually show what these are. So again, these are non-aortic. The aortic guidelines that we've shown you for this evidence base has been from literature review, but these are more people's individual in-house enhanced recovery pathways and what they show. So McGill has some great patient education, and this was basically started with the ERAS protocols that they were doing for GI procedures, and then they developed a lower limb bypass surgery one. And that I think what's really great is it's just easy to see about what they're describing to patients, a lot of pictures, and from the educational standpoint, talking about what's going to be done in the surgery, and then general risk factor modifications of how to prepare for it. And then more specifically, their pre-admission checklist about testing that may be involved, and instructions for day of surgery, what not to do, and then more specifically for getting into this interval about what foods not to eat and what to eat, things that are more just general patient information, and then what types of things they might see attached to them, and thinking about issues of pain control and exercises towards early mobility that may not be even necessarily fully coming out of the bed. So this was just really nice in that it's very patient focused. I think that as surgeons, we often forget some of the health literacy restrictions that might be in play for patients. And I can speak to that even in terms of this was University of Washington's amputation, what they were calling a care map, which was sort of their patient instructions, which is more concise. So it's a little bit of pictures, and then starts about how they're using the carbohydrate load for them and changing NPO status, as well as after surgery, some different exercises. And so this is part, having in your preoperative counseling formal documents or videos that patients can refer to is really important. It shouldn't just be the ad hoc, what can I tell you in 5 minutes when I'm sitting before you. That for our lower extremity paper, I seem to have closed it. We have an amputation one that also has some pictures, but also has way too many words in terms of what we tell the patients of specifics for before that. The University of Washington has shown that there is some financial impact to these, which is important data potentially in terms of that pathway to implementation of being able to persuade your hospital leadership that this should have issues of nursing support or quality support to it, and reasons for engagement, especially if there's potentially less enthusiasm across collaboration between different specialties. And then for more specifics, that what I wanted to show you on the UAB one was that the actual power plan that our hospital computing helped us build, and that we have elements of it that are pre-checked. and then other ones that are more optional or patient specific based on their individual risk factors. And so developing something like that is really important to be able to expand implementation across a whole group of different people. And then in a more concise way, Dr. McGinnigal had this for their major limb amputation ERAS pathway about what we're specifically talking about when we think of multimodal pain control and different types of blocks and aspects. This is just very concisely put together aspect when you're starting to think about what these protocols might mean for your own institution. So I'm happy to share any of those resources with people by email, and that I would say that McGill, UAB, University of Washington, UNC also have all published some aspects about their care.
When we send out all of the information about CME and other VQI business, we can attach all of these documents that Dr. Spangler just shared with us.
Oh, and I guess the last part was, I mentioned this is semi-blinded, but if your institution also does have NSQIP in terms of some of these aspects of counseling, clear liquids, use of regional and multimodal anesthesia, Foley removal, and IV discontinuation, what our team did was basically recruited our NSQIP nurses who are already abstracting the lower extremity specific modules of these patients and asked them just to fill out this portion of the colorectal ERAS part on those patients, which gave us a sense of how we were doing with our implementation that didn't involve having someone do de novo chart review. It was someone who was already having to look in those charts for other purposes.
Yeah. There's quite a few other institutions, UNC among them, who have done their own like automated data abstraction. I can share that information with you for those of you who are on Epic, but I spent the better portion of 2 years going through about 100 different process measures for all of the different 20 ERAS pathways that we use at UNC and figuring out which of those could be immediately and automatically extracted from Epic without any person doing data entry. And so we, I mean, I'm sure at a high cost to the healthcare system, but we created our own dashboard. The ERAS Society also supports an ERAS specific registry that has hundreds of process measures if you really want to get into the nitty gritty. And then something at a national level in the VQI that we're starting to talk about is what is the best way to include some of these concepts into the VQI without increasing the manual kind of double data entry. And so I'd be, for all of the program managers who are on the call today, I'd be really interested to talk about in the breakouts and also afterwards of what might be helpful to you. The options that we've thrown out so far are just a simple yes, no, like was this person intended to be on an ERAS protocol or not? And then if you click yes, we can see after some years if the people who have yes clicked have better outcomes than the people who click no. We thought about doing a more comprehensive like add-on bundle that could be added to the institutions who did not have their own kind of in-house data auditing process, but wanted to have a very detailed way to track the compliance with ERAS. And then there's kind of a middle ground one that's similar to what's done in NSQIP with just a few things like, did the person get multimodals? Did the person get their Foley out, their IV fluid stopped? There's just a couple of things to add to the post-op care that we're already doing. And so any of your feedback on that, as you get familiar with this and think about it, would be helpful to us at the VQI. I'll also put a plug in for the actual ERAS Society. The ERAS Society is an international society, and there's a ERAS USA branch. Through my work with ERAS, I've actually gotten very involved in that society as well. And they have a lot of different webinars and tricks for how to implement ERAS and to leverage the existing resources at your institution so you're not totally starting from scratch. There's a lot of information available on the ERAS Society website, which I just put into the chat. And then also, if you're interested, the ERAS USA meeting is usually, it's a nice small multidisciplinary meeting of maybe just a couple hundred people. And it's a really good way to kind of talk about what works, what doesn't work, and to talk with people from different specialties and also from like finance and admin portions of healthcare systems, you know, to help show return on investment and the value proposition. And so that meeting is usually annually in November. This upcoming one is going to be in Washington, D.C. this November if people are interested in joining me there. And Emily and I will be talking about ERS again at the BQI VAM meeting next month in June.
Okay, I'll go ahead and stop my share.
Betsy, I think it's time for breakouts to try to get everybody else's thoughts about ERAS and what seems to be good, what seems to be a barrier, what seems confusing. So we'll take it to the breakouts, and then remind me what time, how long are we going to do in breakouts, and what time do we need to be back to kind of do a wrap up from each breakout room, Betsy?
So we have 15 minutes for breakout rooms. We have 4 breakout rooms. You've all been randomly assigned, given the RSVP list that Lika provided us. And Jen is going to help me. She's going to tell everybody we have 4 breakout rooms, one with Dr. Long, one with Dr. McGinnigal, one with Dr. Genovese, and one with Dr. Marib and I together. So our wonderful technology, Dr. Marib is going to have to be on the phone with myself. So Jen, do you want to just kind of say a quick little blurb, and then it'll be for 15 minutes. Then we'll come back and have an open session for like 10 more minutes, Dr. McGinnigal, and then we'll move forward.
Sounds great.
Okay.
Thanks, Betsy. I just want to just a quick couple things. As Betsy mentioned, the time frame will be 15 minutes. You'll all be notified and automatically sent back to the main room here. There will be one group that stays in this main room, and then 3 groups will go into separate breakouts. And just bear with me, because once I open the rooms, you might have a pause where you feel like the call's dropped. It hasn't. It's just there's going to be some dead air both going in and out of the room. Okay, so I'm going to open those rooms now, and we'll see everybody back here in 15 minutes. Dr. Long, it looks like we have a pretty good sized group still in this main room, but I think some people were not able to be assigned to a room. So whenever you want to get started, I think it's fine.
Oh, that's fine. I didn't know if you were still pulling people out or what was happening there.
I'm trying to, I'll do that while you're still talking and just see how the other rooms are coming along, but I think you're okay to get started.
Okay. Well, I mean, I thought the ERAS talk was actually interesting. I think many of those things, as Dr. Brothers alluded to, I think we probably do. Some of the things that we don't do a very good job is use of like IV Tylenol and other non-narcotic agents following surgery. I don't know if that's something that's similar at other institutions, but I would be interesting to hear what practices people have around their aortic surgery. Do people do the carbohydrate challenge prior to going back to the operating room? Is that something that's utilized by the anesthesia team or what have you? And where we differ, where we're the same, and maybe how we think of a consensus on maybe how we move forward, so to speak. I got no sound from you, Tom. I'm sorry. I guess one question: are generally people opposed to adopting many of these things if we're not, or are there any people that object to certain criteria or recommendations? Is anybody there?
I was gonna ask, are people able to unmute, or is anybody?
Hey,
having-
Dr. Lung, can you hear me okay? This is Doug.
Hey, there you
in
go.
Nashville. Yeah, hey there. So sorry, I've been struggling with my phone a little bit, and I'm actually working today. So I did not get to hear the beginning of the talk, but I appreciate you guys addressing this. You know, one of the comments I had is, you know, I think we are all using kind of a streamlined preoperative and postoperative order set here, mostly based on a lot of these ERS guidelines. They haven't necessarily come out of the ERS. And one of the comments I made in the chat, I'm not sure if it came through. I often struggle with these little devices, but what we found is that we've had a lot, a large determinant of how our patients do postoperatively is a function of what happens in the operating room. And, you know, I don't know that I've actually even seen the VQI data abstraction forms, but it would be interesting to put in certain variables about how the conduct of the operation goes. And I mean, we could talk probably longer than we have about what those elements would be. But it would be certainly an interesting thing to do. The other comment I had is when I heard that this was going to be discussed, I went and pulled our data from the beginning of the year in terms of aortic surgery and found that only a third of the cases that we have done have been captured by VQI because of exclusion criteria. And I know that's been a topic of conversation. But I think that, you know, this certainly a new day and age where there's so much done with endovascular techniques that preserving and maintaining excellence with open aortic surgery is getting more difficult. But I think that it would be nice to see us capture all of our open aortic work in the database and really look at intraoperative variables that really do determine outcome. And I mean, I'll just say one right off the top of my head. We do any sort of suprarenal or supraceliac clamp with 2 attendings. And, you know, that's just a variable for one example. And I could go on and on about stuff. But I just didn't know if there was any discussion, because I haven't been able to attend all of these, about capturing more data and looking at those intraoperative variables to help everyone kind of compare and contrast and discussed. These are obviously complicated cases.
Doug, that's awesome. I appreciate those thoughts. Let me just give a minute to see if anybody else has comments, and I had some thoughts about what you said. Maybe not right down. So it's interesting. You brought up a couple issues I thought were very interesting. I think the conduct of the operation is something that, especially with it being done less and less, is something that we should focus on more. I remember there was a poster presented at the Southern Vascular where they talked about open aortic surgery, and they were talking, especially with regard to suprarenal clamp, like what's the element of disease in the renal arteries prior to starting the case when you're doing that. But the thing they didn't hit on is what the operative time was, what the resuscitation volume was, what the blood loss was. And all those things, I think, play a huge role, because I think it's really kind of the pressure head going through those renals that really preserves renal function, so to speak. And Lila and I, when we were reviewing our aortic data, I don't want to quote the exact number, but there was a substantial amount of missing data points or missing elements, even within our post-op open aortic cases. So I think there's a lot of room to go with regard to that. Did you have any thoughts about particular aspects in ERAS? Like, I don't know, doing the glucose challenge, the way we can change. We're a big regional anesthesia center, for better or worse, in many ways. And so we do a lot of spinals and regional stuff to help with these cases and epidurals, so to speak. Do you have any thoughts on that?
Well, the carbohydrate challenge is not something we do, and I'll bring that up with my partners to discuss. Maybe that's something we need to investigate. The regional anesthetic techniques we use extensively. I think we're pretty much in compliance with everything that's been mentioned. Aside, we don't do early feeding. Let's see, what was the other one you guys had mentioned? We do not leave NG tubes in unless they've had a longer than desired supraceliac clamp. That might be a reason to leave an NG tube in a little longer. But for the most part, I think we're following everything. The carbohydrate challenge is interesting, though, because we're obviously doing blood glucose checks, but we're not doing anything that sensitive.
How do you do with early ambulation? Our cardiovascular ICU, especially the cardiac patients, they're walking day one, and in some people who are even still vented, they are getting them up out of bed and walking, which is amazing. In the surgical ICU, it's an act of Congress to get anybody out of bed, and so that's something we've seen a difference in terms of where our patients go post-operatively, and how well they do.
There's no question that we see a direct correlation between the quality of the nursing care and the attentiveness of the nursing care as it relates to walking and incentive spirometry. If the nurse is at the bedside working on these things, these patients are a mile ahead of the patients who don't receive that care. And just like you described, our cardiovascular ICU is the primary place we take patients, but if they are overloaded with patients, they will go to a different ICU, and it's not as good. And that they're just not as in tune with what our priorities are. So pretty much the exact same experience.
And then how many? And you only have 2 attending involved cases for suprarenal or supraceliac clamping?
It's a judgment call, but if you think there's going to be anything other than the easiest proximal anastomosis with an infrarenal clamp and a nice rubbery ring to sew to, we usually bring 2 in there, and we just comment to each other all the time how much easier and faster that proximal goes if the person helping you doesn't have to be told what to do, and they've done it themselves and they know exactly how to follow and set you up, and they can communicate with anesthesia while you concentrate on what you're doing. And it's probably helpful to the surgeon's just emotions to be able to have that level of support while doing something that's stressful. But there's no question our clamp times are much lower if we have that kind of assistance compared to someone else.
And then this is just since we got time, are you, if all things being equal, are you being more aggressive with volume resuscitation to push the kidneys at the expense of the lungs, or are you minimizing fluid to protect the lungs at the expense of the kidneys?
Case by case, it depends on what appears to be more threatened. Somebody with an ejection fraction of 40% and had an infrarenal clamp will obviously be a little more careful with fluid resuscitation. But if somebody's had a suprarenal clamp for, an average period of time, but we know that their cardiac function is good, we'll be more aggressive with the fluid. Obviously, if somebody stays intubated, we'll be more aggressive with the fluid because we know we can ventilate through the fluid. But for the most part, we are really shooting for euvolemia and, trying to keep, and this is kind of where my comment came from. I find that these things are a lot easier to manage, and it's a much more forgiving environment if that clamp time is low. If we can keep the clamp time low, which is, a function, I think, of doing them frequently and having the assistance of an attending, that sure makes postoperative fluid management a lot easier. But, when you start hitting, 25, 30 minutes above a renal, then all of a sudden you've got to be careful. I mean, it's just harder. I mean, their kidneys will probably recover, but it's just harder.
Do you have any thoughts on approach, retroperitoneal versus transabdominal?
We do both. We certainly do more transperitoneal than retroperitoneal. If we have to get to, between the celiac and the SMA or some weird clamp, we'll go retroperitoneal. Or if there's some sort of hostile abdomen, we will. The transperitoneals are what we do the most here. And we have pretty good access to our clamp sites that way. And we're just we're just used to that. It's comfortable for us. So I would probably say at least 80%, if not more, transperitoneal.
It's interesting because you talk about resuscitation, you talk about recovery of bowel, retroperitoneal approach. Those are the big arguments for, less incident of losses, less faster recovery for bowel. And I just wonder if that's a technique outside of maybe the Albany experience and stuff like that. I think it's not commonly done for exactly the point that you talked about, unless you're clamping the visceral segment. But I don't know, is that something we should be thinking about more, even for infrarenal clamps?
One of our partners who is newer to our practice came from the West Coast, and he did almost exclusively retroperitoneal before coming here, and he still does a generous amount of that, and he's very happy with it. And he cites all the literature talking about better pulmonary function. And what we have kind of found, and we can't put data to this, is that if we are if it's a relatively efficient operation and clamp times are low and we don't do deep pelvic dissection, they seem to recover very well as it relates to pulmonary and GI function. Where we see the prolonged ileus and is really a function of how deep in the pelvis we go. When we start doing internal iliac work, we have to expose that deep. It just seems to have a more profound effect on ileus. And obviously those are harder places to get retroperitoneal on the right side. So we tend not to do that for complicated iliac work, but that seems to drive the GI component. I have not noticed a big difference in pulmonary complications between the two, but I can't say that we've done enough of both to really know.
I'll just keep picking on you, Doug, since you're the only game person here. And next in person, bourbon's on me for you.
Deal.
But so have you noticed any difference in hernia rate with the retroperitoneal versus transperitoneal? I mean, it's harder to fix those retroperitoneal. And the other thing I was going to ask is cost effectiveness. Here we have trouble. I like IV Tylenol, and there are certain stipulations that the patient has to be NPO for a long period of time, and not to get on oral stuff for us then to pull the trigger because of the cost. And the cost is not exorbitant, but it's just simply more expensive than some of the other more cheap availabilities. And I just wondered if you guys run into those sort of problems as they talked about using non-opioid forms for pain control. So two-part questions. And
so the retroperitoneal hernias do seem to happen, and as you know, they're complicated, they're hard to fix, so a lot of people walk around with a bulge. The abdominal wall hernias, we follow everyone for life, but having said that, we still probably lose people years later from their open aneurysm repair. So I do think we probably underappreciate small bowel obstruction and hernia formation relative to how frequent it actually occurs. So I would say that our rates of hernia formation are in keeping with literature. It's probably 1 in 5 patients gets our abdominal wall hernia from transperitoneal, but at the same time, we may be missing some. As far as IV Tylenol, I've never used IV Tylenol. And I don't think we use that on a regular basis here, but you may be talking me into it, because we certainly want to minimize the narcotics. Obviously, that creates problems, but
Chandler, why can't you just give them Tylenol pills?
I guess you could. I mean, again, still old dogma that we need to get around, but even just giving it to them the day of surgery and doing those things. I mean, number one, I found it to be more efficacious in terms of even pain control, to be honest with you. And that was from experienced resident.
PO Tylenol doesn't seem to be very good at pain control in my experience. Now, IV may just be a different, it may make all the difference. I don't know. I've never tried that. We'll periodically hit them with IV.
The bioavailability of IV and PO Tylenol, it's exactly the same. And so.
Is it really?
Yeah. I know this because when IV Tylenol became available, I also loved it and I also used it. And then I also got told by my hospital it was too expensive and I couldn't use it anymore. And we went through this whole process with the pharmacy and the value-based people. And the bioavailability is totally the same. And if you use it routinely and not just for breakthrough pain, but schedule it, then we found that it works pretty well. Just the pills.
Good to know. We might need to try that again. But, well, I actually have to run down to my case. But hey, guys, thank you so much for including us in this. Lem Kirby is our leader with VQI in our practice, and he is not available today. I wanted to jump in. And we do have a great interest in aortic surgery up here, and would love to continue this dialogue and learn as much as we can from you guys.
Likewise.
Thank you for your participation. Kate, do you have any thoughts?
Yeah, well, maybe each of y'all can just kind of give a summary of what you talked about. In my room, we had 2 other surgeons and 6 data abstractors or quality people, and everyone was pretty excited about ERAS and willing to adopt the parts that they hadn't already adopted. Everyone kind of knew what ERAS was and had other programs in their hospitals. We talked a little bit about barriers to adoption, just being getting it ingrained in the system in terms of administration and nursing, and then working on all of the pre-op outpatient stuff, transitioning into the hospital and then transitioning out of the hospital, and kind of keeping track of the outpatient parts of the ERAS pathway is a little bit challenging and variable. Liz, what did you all talk about in your group?
About the barriers as well. I think the biggest barrier that we saw were some of the GI aspects of it. So being able to have clear liquids up to 2 hours beforehand, and getting buy-in from anesthesia and the OR staff, and then the early refeeding part of it. But I think a lot of it is the buy-in from anesthesia. So some folks indicated it, not necessarily being able to get that moved through their system. But we talked, I was interested, I haven't actually read the document myself about the data behind it for vascular patients, to be able to bring that to the Department of Anesthesia at different institutions.
Chandler, how about in your room?
We had some telecommunications issues and a lot of excitement that wasn't able to be expressed. but essentially, I from the few that participated, I think that people are generally in favor. Obviously, I like the aspect that it's not an all or none deal, and there's some nuances that can be tweaked. But in general, I think it's aspects about talking to our anesthesia colleagues about the carbohydrate challenge prior, working with them post-operatively to make sure that we're using lower opioid or non-opioid regimens is probably totally reasonable. We use a lot of regional care here at Duke. I don't know how that's being done at other facilities, but I think it's more about communication and just getting other stakeholders, because it's beyond just whether the surgeon wants it. There's a lot of support, whether it be anesthesia, nursing, OR staff, and even our trainees or APPs for that matter, kind of being on board with it. So from the people that participated, I think there's some agreement there.
Cool. And then Lila, were you able to do your room? Or I know that Duke has some like ridiculous firewall, so maybe Betsy had to lead that room.
Oh no, Lila did fantastic.
Oh, good. What'd you guys learn?
So we talked about some of the barriers to adoption of ERS at our facilities, and we actually started talking a little bit about the sort of technology issues, whether it be, based on our EHR, local IT support, to try and help with that.
Does anybody have any other burning questions? Thoughts about what their next step should be to start implementing aortic ERS at their hospitals?
I think something else that we shared, Dr. McGinnigal, was that searching out a champion, truly finding a champion, whether it's starting out with the anesthesia champion, nursing champions, just to kind of really help with that.
Yeah, that's absolutely true. The ERS Society has a lot of information kind of about ERS implementation and implementation guides on like how to build a champion team, and how to kind of help hold everybody accountable to, progressing an agenda through, and then showing return on investment to the financial folks at your hospitals. In general, when ERS is done well, it actually reduces the amount of nursing work, and it reduces readmissions, and it creates more backfill opportunity to get more operations in. And so a lot of that work has already, been shown. Of course, everyone has to show it in their own institution, but we're lucky in that we're late adopters in actually having a formal ERS guideline, that the other general surgeons have done a lot of this work already. And so hopefully getting the technology part and the IT support and the auditing and actually getting plugged into the quality program at your hospital, it's always onerous, but hopefully it'd be slightly less onerous for each of us, since the pattern is there, and the popularity of the program and other specialties is there. A lot of that's available on the erssociety.org website. A lot of it is going to be available within the VQI website. They're partnering with the ERS Society, and obviously there'll be more to come, and we'll give all of the information that Dr. Spangler presented to us. We'll give all of that literature to you guys on email after the meeting. All right. I think that pretty much wraps it up. And then Betsy has some national VQI updates that she needs to run through, just to kind of let us know what the PSO is up to. And then we should finish up and everyone can go have lunch.
All right, can everybody see my screen?
Yes.
Okay, awesome. All right, so currently we have 928 centers participating. And again, we still have our 18 regional quality groups. And currently we have 936,887 procedures captured. Our top registry is the PVI. And I did want to point out, during COVID, we decided to start our vascular medicine consult registry and our venous stent registry. So we're still kind of low with our enrollment in those. So just wanted to remind everybody about those registries. And if you have any questions about those registries, please feel free to reach out. We'd love to talk to you about those. VQI at VAM, it's coming up very soon. It'll be in Boston this year. It begins Tuesday afternoon, June 14th, and it goes through June 15th with VAM to follow. So we're excited this year. We have 18 posters, and the poster presentation will be from 5 to 6:30 p.m. And we actually have 3 FIT trainees that are authors of the posters this year. So please stop by and see the posters. So our long-term follow-up reports are currently available in the EVAR carotid artery stenting and carotid endarterectomy registries. They're going to be soon released in the PVI, TVAR, IVC, and HDA registries. The report features include the ability to customize reporting timeframes, filters, drill down functionality, and then comparisons for my center, my region, and all VQI. Device assist and symmetric integration. Dr. McGinnigal spoke about this earlier. Just want to point out it is coming soon. Device Assist is a new device search program within Pathways, and it allows centers to search for their devices in a cleaner, more efficient manner. Device Assist is powered by the Symmetric Health Solutions, and again, it's available in the PVI registry coming soon. The partnership with Symmetric Health Solution, it's actually an industry-leading software company for healthcare supply chain data, and it enables the SBS VQI to eliminate inaccuracies and variances in medical device reporting, which can carry clinical consequences. It will also strengthen the SBS VQI's commitment to interoperability by ensuring that our data is clean and consistent across all health system IT interfaces. So again, that's coming soon. The MyPad Pro pilot, many of you are aware of this. Dr. Danny Burgess is leading this, and they're actually extending this pilot. So the MyPad is a patient-reported outcomes pilot program, and again, it is for the PVI registry, and it measures the quality of life changes after endovascular treatment of peripheral vascular disease. The pilot was launched in April of 2021, and their first analysis of data went through December 2021. It's actually very encouraging. Their data analysis is going to be presented at VQI VAM by Dr. Burgess himself. If you're interested in joining the pilot program, please contact Carolyn Morgan, and her email is right there on your screen. It's cmorgan@svspso.org. And she can provide education and any promotional documents and answer any questions that you may have. So we are redoing our website. We're so thrilled. We're getting a new VQI.org experience. It's going to be a new look and feel, fresh content, and most importantly, an improved navigation. We're actually going to give another sneak peek at VQI at VAM. So VQI at VAM this year is going to be action-packed, so coming soon. Also, we have a VQI LinkedIn. In fact, I don't know if many of you saw the Carolinas region with the keynote speaker, Dr. Spangler, was promoted this year. So that's just something that we started, and we're super excited. So look for more on VQI LinkedIn, and also join us, join our page. We're also adding a VQI mobile app. This is actually going to be started after we get our website up and running. So more to come on that, but it is coming. And also, again, Dr. McGinnigal had shared that Dr. Jorgensen attended a two-day conference at the FDA. And this was a two-day FDA panel on the type 3 endoleaks and endologics EVAR graphs and the value of real-world evidence for device evaluation and device surveillance. The panel conclusions on the endologics EVAR graphs that had a history of endoleaks, and it was unclear whether the mitigation efforts by endologics were successful. So the next steps were for the FDA. The real-world evidence is important for device surveillance. The length of follow-up data should be for at least 5 to 10 years, and then current follow-up has been decided as inadequate and centers truly need support. So better follow-up can be obtained using VQI as a basis or linkage with Medicare claims. Paclitaxel, the VQI played an important role in the paclitaxel controversy. There were two separate analyses of paclitaxel devices using the VQI data. There was one with a software application and the other with claims linkage with Medicare data. And then in conclusion, neither the Delta or the Vision analysis showed any association between paclitaxel devices and mortality. Just wanted to remind you, make sure when you sign in to put your full name, so you can get your CME CE credits. You'll have 7 days to complete the evaluation, and Jen's going to put the CME link into the chat box now. And again, put your full name. If you forget, type in the chats, no problem, we'll help you out. Or you can just send an email to Lika Johnson, ljohnson@svspso.org. Here's the link if you just want to use that. Again, you have 7 days as a reminder to complete the CME CE link, or we'll also put it in the chat for you. So just some quick quality improvement updates. So our trainee program, and once again, as Dr. McGinnigal had just mentioned, this program is a mentor-based 12 to 18-month program. We started our first program, and we are in our first pilot program. We're super excited about it. Using a mentor-directed approach, our FIT applicants work closely with their VQI mentor on participation in regional biannual meetings, and they review comparative data, including central-level quality improvement processes. Opportunities include engagement in quality charter development, center-level QI process, and research initiatives using the VQI data reviewed by VQI RAC Committee. Advancement through the 12 to 18-month program provides the FIT applicant an opportunity to present their work during the VQI exam with potential selection for a highly coveted Jack Cronowitz Scholarship. The first scholarship is actually going to be awarded in 2023. A lot of people have been asking about that. The SVS PSO staff have quarterly check-ins, and we will be offering satisfaction surveys to obtain feedback so we can learn from our program of how to improve it, how it's going. And if you have any questions or feedback, comments, please contact either Dr. Gary Lemon or myself, and our addresses are right there. So we do want to acknowledge Dr. Mitchell Cox and Dr. Roberto Luanzan. I probably just butchered his name and I apologize, from Duke. And this is a complete list of our 2022-2023 FIT mentors, trainees in their respective centers. So we're proud of them. So what's next? So you can sign up to be a mentor at any time. We're going to accept our next trainee applications to coincide with the academic calendar year. So the next trainee application is January 2023. You can check our website frequently, www.vqi.org, and then I actually put the actual hyperlink here. There is a specific tab for mentors and a specific tab for trainees. And we also started a little tweet for our trainees and mentors, and it's #NextGenVQI. Our 2022 Participation Awards program, we haven't changed the 4 domains. So moving forward, Domain 1, long-term follow-up, Domain 2, regional meeting attendance, Domain 3, QI projects, Domain 4, registry subscriptions. The only thing that changed this year is just a little verbiage in the QI domain. So when you present a QI project, usually such as this at a regional meeting, when you present at succinct regional meetings, your project slides must reflect a change or update in status. So if you're presenting the same slides, just state, no change, or, it just has to state specific, no change, or just an update. That's all. And if you have any questions, just feel free to reach out to me and I'll help explain it. And with that said, I want to congratulate everybody on your 3-star, 2-star, and 1-star. So here's a big handout to everybody. So congratulations. Let everybody take just a moment to look for your center there. That's a huge achievement. So congratulations. Charter history. I was just kind of curious as to our historical charters, and I want to say kudos to all those data managers and physicians and centers. There were 74 charters submitted for 2021, and as of today, we have 24 charters already submitted. So kudos to everybody. And again, you can see the breakdown on the left-hand side, all the way from 2018 up to 2021. The only thing about charters is that it must be based on VQI data. So speaking of charters, how do you begin a charter? You can attend charter focus calls, listen to prior webinars, review sample charters, network with your colleagues, or you can just give me a shout and we'll have a one-on-one meeting. For quality improvement, what do we offer? Again, we offer charter focus calls. There is a new format. Just make sure that you go on the website and register for those calls. We offer quarterly webinars, a monthly VQI newsletter, sample charters, and an overview of the QI tools. And there's a hyperlink there for you to click on. And now, just wanted to give Dr. McGinnigal a quick little shout and ask everybody if they have an opinion. The next call for the fall 2022 Carolinas Regional Meeting will be Friday, November 4th, and wanted to ask if anyone has a preference to do it in person, hybrid, or remote. And you can chat in the chat box or take yourself off mute. Or would you like to do a doodle poll? We have an in-person, hybrid.
So for all of you who are saying hybrid, that will mean that we can no longer do it at the Grove Park, and we'll have to find different places, which is totally fine. But if you particularly love in-person meetings at the Grove Park, then we'll have to make it in person only. And for those of us who have more trouble traveling, a remote option would not be available.
We have some remote.
Ooh, 50-50, it's all over the place.
Yeah, exactly, it is. So do you want to do a doodle poll, Dr. McGinnigal?
Yeah, I think we'll send out a poll if you guys could help and do that.
Absolutely.
And, I think that one thought that I have is one in-person meeting per year would be nice. It really helps build community, and talking to a computer screen for the last 2 years, I've gotten used to it, but it's kind of lonely. And doing it remote, though, I think facilitates better attendance for people who don't have travel budget or have a hard time taking the time away to travel if you've already got a lot of other meetings that you go to. And so I was thinking one in person, one remote, and with the option of maybe having the in-person meeting hybrid if it's affordable. A lot of hotels have gotten wise to that, and charge you twice as much to have an in-person plus AV stuff. So I'll give a variety of options and also a variety of locations. We don't necessarily have to do it in Asheville and in Charleston. Are there any other centrally located and easy to get to places in North or South Carolina that people would want to visit? That's going to be another question on the survey that we send out. Oh, and Eva says Pinehurst. That's always a good option. Tom Brother says he wants to go to Carowinds. I don't believe you that you're kidding, Tom, and I will definitely join you on a roller coaster after the meeting. Cool. All right. Well, guys, thank you very much for all of your attention. I'm glad that we can sneak out of here 15 minutes early. I am super excited for all of you for persevering and still having just remarkably good outcomes in the VQI. And I'm confident that we'll sort a way through our mortality problem with suprarenal bypass and elective aortas. I know a ton about ERAS, and Dr. Spengler does as well. As you guys are starting out with your ERAS thoughts, please do reach out to us and let us know how the VQI can help support these ERAS endeavors, or if you want to incorporate ERAS into one of the charters. Everyone at the PSO is kind of getting up to speed on ERAS, and will hopefully be able to support you, but feedback is so important for that. So thank you guys so very much, and we'll be in touch via email soon.
Thank you.